Hello and welcome to this part of the video. In this video, we are going to discuss the examination of the cerebellum. Like in all our examination videos, we are going to start with some of the theories you will need to know. Then we'll proceed to perform the examination proper. So we'll start with the basic theories you need to know before performing the examination. Then go ahead to perform the examination proper. Now, the cerebellum is the part of the brain that coordinates voluntary movements. It also helps to maintain balance and posture. And it also helps to regulate muscle tone to ensure smooth and accurate motion. So any lesion to the cerebellum can affect any of these functions, and this will lead to some of the classical signs we will see. In fact, we'll call it the 3Ds, or the 3 core signs you will see in cerebellar lesions. The 3Ds, one of them is dysmetria, which is inaccuracy in targeting movements. So when the patient tries to target a particular thing, it tends to overshoot or undershoot. So this is dysmetria, and it's caused by a lesion to the cerebellum. Another classic sign is Dysdiadochokinesia. So this is the inability to perform rapid alternating movements. Okay, so when the patient tries to perform a rapid alternating movement, they may not be able to do that. So it's one of the classic cerebellar signs which occurs in cerebellar lesions. The next classic sign is disequilibrium, where the patient might not be able to balance, or they might have unsteady gait, where they tend to veer to one side when moving. So the patient might lose their balance and have an unsteady gait. So this is disequilibrium, one of the classic signs of cerebellar lesion. Now, apart from all these 3Ds we mentioned, there are some additional classic signs you might see in cerebellar lesions. One of them is intention tremor. This is tremor during movement, which is worse near the target. We also have what we call ataxia, which is uncoordinated movements. It can be limb ataxia, trunk or gait ataxia. Then we also have Nystagmus, which is involuntarily jerky eye movements. Then we also have hypotonia, which is reduced muscle tone. Remember how we said that the cerebellum helps to control the muscle tone. So we might have hypotonia as one of the signs of cerebellar lesion. So we might also have what we call scanning speech or staccato, when there's irregular rhythm and emphasis during speech. These are some of the signs you can get when there's any cerebellar lesion. Now, in a cerebellar examination, we'll try to observe or try to elicit signs that will help us check if any of these classic signs are present. Now, there are 8 components of this examination, of cerebellar examination generally. The first one is general observation, where we're going to observe the patient for hypotonia, maybe ataxia. Then the next one is the speech assessment, where we'll try to observe the scanning speech we talked about. Then we have the eye movements, where we'll try to observe for nystagmus. Then we have the finger-to-nose test, where we'll try to observe for dysmetria or intention tremor. Then we have the rapid alternating movement test, where we'll try to check out for Dysdiadochokinesia. Then we have the Heel-to-shin test, where we'll measure the dysmetria and ataxia. Then we'll have Gait assessment, where we'll measure disequilibrium and ataxia. Then finally, we'll perform the Romberg test, where we'll try to check for disequilibrium. These are the 8 components of the cerebellar assessment. So in observing the patient, or generally looking at the patient even before the exam, you tend to note if there is any reduced muscle tone or any floppiness. Then you also check for general ataxia, which is uncoordination in posture and voluntary movements. So these are some of the things you can observe even before the examination begins. So in observation, we're going to check out for reduced muscle tone or floppiness. Then we also check out for general ataxia, which is uncoordination in posture and voluntary movements. Then after that, we'll go to speech assessment, where we'll check for what we call scanning speech, which is irregular rhythm and emphasis during speaking. So it's staccato quality. So in the initial observation, we're going to note the patient's posture at rest. So we're going to observe any tremor or involuntary movements. So we're also going to watch out for truncal sway while sitting. We're also going to note the patient's coordination during undressing and positioning for the test. Then after the initial observation, the next is the speech assessment, where we'll try to engage in a normal conversation with the patient. Then we can ask the patient to say specific things such as British Constitution, baby hippopotamus. So when we tell them to say these things, we'll listen for any irregular rhythm or scanning. We also listen for things like slurred speech or slurred quality and syllable separation. Then when we are done with this speech assessment, so the next component of the examination is the eye movement, where we are going to check for any involuntary rhythmic eye movements. So we're also going to look for what we call ocular dysmetria, where there will be overshooting eye movements. So after assessing the eye movements, we are going to also check out for the next component is the finger-to-nose test, which helps us check for upper limb coordination. So in this place, we are checking out for dysmetria. There might be overshooting, which is known as hypermetria, or undershooting, which is known as hypometria. There might also be intentional tremor, so tremor appearing during movements, or it can also be worse near the target. There might also be what we call decomposition of movement, which is breaking of smooth movement into segments. So the finger-to-nose test helps us to test for dysmetria, helps us to check for intentional tremor, and also helps us to check for decomposition of movements. After the finger-to-nose test, we also perform a rapid alternating movement test, which will help us to check out for Dysdiadochokinesia, which is inability to perform rapid alternating movements smoothly. Now, during this test, we're going to observe the speed of movements, the rhythm regularity, and then the breakdown of smooth movements. Then when we are done with that, we move on to the 6th component, which is the Heel-to-shin test. This one will test for the lower limb coordination. In this test, what we are looking out for is lower limb dysmetria, which is inaccuracy in leg movements. We're also looking out for what we call lower limb ataxia, or jerky uncoordinated motion of the lower limb. We're also looking out for tremor in the lower extremities. After that, we'll go over to Gait assessment, where we're also testing for disequilibrium or balance problems. So here, we also check out for truncal ataxia, which is midline instability. We also look out for gait ataxia, where the patient might have broad-based gait when they are trying to steady themselves while walking. We might also have what we call lateralization, where the patient will be veering to one side during movements. After the gait assessment, we'll finally perform what we call the Romberg test. These tests will help us differentiate cerebellar ataxia from sensory ataxia. In cerebellar ataxia, the patient is unstable with the eyes open and the eyes closed, whereas in sensory ataxia, the patient is stable with the eyes open but unsteady with the eyes closed. So this is the positive Romberg. So the Romberg test helps us to differentiate between the cerebellar and sensory ataxia. And the Romberg test will conclude the cerebellar examination. So these are the 8 tests which we'll perform during cerebellar assessment. So we're going to go ahead to demonstrate this to you. If you found this video helpful, please drop a like, subscribe if you haven't already, and turn on your notification bell so that you don't miss the next one. Also share this with your friend who might need it. Now in this segment of the video, we'll try to demonstrate everything we talked about in the theory section. Now, like in any other examination, we have the pre-exam, the examination itself, and the post-exam. So in the pre-exam, you greet your patient, you introduce yourself, then take permission for what you're about to do, then you perform your hand hygiene, then you can now go ahead to start your examination. Then in the post-exam, you thank your patient and probably explain some details of the examination to the patient. So this is pre and post, constant for every exam, before you go ahead to your main examination. So now we're going to perform our pre-examination. Hello, good evening.
Good evening.
My name is Dr. Henry. Okay. So I would like to perform an examination on you, which will involve me testing your balance and then your gait and so many other things. Can I go ahead?
Okay.
Then perform your hand hygiene. Now, like we said, the first component of this exam of cerebellar examination is the observation or the initial observation. So immediately, even before we started interacting with the patient, I was already looking at the patient, checking out for patient posture at rest, checking if there is any tremor, any involuntary movements, or any truncal swaying while he's sitting. Okay, so we actually started the initial observation even before talking to our patients, looking at the posture of our patient at rest. Now, with this, we are done with the observation or the initial part of the assessment. The next is speech testing or speech assessment, where we will tell the patient to say specific phrases to enable us to check out for some of the things we discussed about in the theory section. So, can you please repeat after me? British Constitution.
British Constitution.
Baby hippopotamus.
Baby hippopotamus.
Good. Now, we are listening for irregular reading or scanning. We're also listening for maybe slurred speech during the pronunciation of these things. So we note that the speech of our patient is actually clear and fluent. Okay. Now during the observation, the patient posture is normal and no tremor was observed. Now during the speech test, the speech is clear and fluent. That's how you report it. If there's abnormal speech, you can say that the speech is slurred with irregular emphasis or syllable separation, depending on what the patient presented with. So, but for our patient here, the speech is clear and fluent. With this, we are done with the first 2 of the assessment. And then, in the eye movements, we are checking out for nystagmus or involuntary eye movements. I'm already looking at our patient's eye to check if there's any involuntary eye movements. We're also going to tell them to follow our finger with only their eyes, and then we'll make the H pattern just to be able to test for any nystagmus or any involuntary eye movements. Okay? So can you please follow my hand with only your eyes? Don't move your head. Okay? When we were making the H pattern, we held it at the extremes to help enable us detect any gaze-evoked nystagmus. So after the observation, we noticed that there is no nystagmus observed in any direction of gaze for our patient. So when we are done with that, the next component of this test is the finger-to-nose test. So this is where we'll test for dysmetria, where there might be overshooting or undershooting. So we'll position our finger at an arm's length from the patient and ask them to touch their nose, then touch our finger. Okay, so sir, please can you touch your nose and then touch this finger with your index finger? Just point. Touch my finger, then touch your nose. Continue. Okay. Continue. Okay, continue as fast as you can. Good. So with this, we are actually looking out for accuracy of movement. Okay, we're looking at if he's accurately targeting our finger and the nose. We're also looking at for the smoothness of the movement. So we're also looking at if there's any tremor during the movement. So we're also looking at the speed or rhythm. We're also looking at what we call the pass pointing, where he's missing the target. So these are the things we look out for during the test. So I remember we're supposed to test each arm separately. So now we're done testing this. We'll tell him to do the same thing with this other arm. Okay. Continue. Good. Okay, then you try to move unpredictably so that the patients can follow you. Okay. So with this, we'll try to move the patient to multiple positions, then note the speed, the smoothness, note if there's any intentional tremor. Okay. So with this, we can notice that the finger to nail test is accurate and smooth bilaterally. Then after this, the next component, which is the rapid alternating movement, where we're going to test for Dysdiadochokinesia. Okay. So we'll ask the patients, sir, can you please bring out your palm? Okay. Then touch. Okay. Then do this. Okay. Do it as fast as you can. As fast as you can. Okay, then can you turn? Okay, then do the same thing as fast as you can. As fast as you can. Okay, so with this, we're also observing the speed of movement, the rhythm and regularity, then any breakdown of the smooth alternation. So our patient was normal. The rapid alternating movements are fast, rhythmic, and sustained bilaterally. Then after that, the next one is the heel-to-shin test, where we're going to test for the lower limb coordination. With this, we're going to need our couch. So we'll move over to the couch for this. So next is what we call the heel-to-shin test, where we're checking out for the lower limb coordination. So here, we're checking out for any inaccuracy in leg movements or any lower limb ataxia or uncoordinated motion in the lower limb. So we'll ask the patient, can you please bring your heel, touch your knee with your heel, okay? Then push it across your leg. Just push it down, okay? Then do it again. Okay, do that 5 times. Continue. Okay, then you can now do the same thing with the other hand. Okay, raise it up, okay. Okay, so with this, we're actually looking out for the accuracy of the heel placement on the knee, ability to maintain the heel on the shin, and the smoothness of the sliding motion, checking out for any tremor during the movement or any side-to-side deviation during the movement. So with this, we are done with the heel-to-shin movements, and we can see that the heel-to-shin movement will perform accurately and smoothly bilaterally by our patients. If you found this video helpful, please drop a like, subscribe if you haven't already, and turn on your notification bell so that you don't miss the next one. Also share this with your friend who might need it. Then after that, we'll head over to the next component, which is gait assessment. Here we'll test for disequilibrium, any truncal ataxia or gait ataxia of our patients. So we're going to do this gait assessment in 2 parts. So the gait assessment, so tell a patient to take some steps and then come back to us. Come down. Okay, in the gait assessment, can you just walk to the end of this room, then come back? So just walk to the end of the room normally, then come back. Okay. Then again, I want you to walk with your heel to your toe, like that. Then to the end of the room, and then come back. Okay. Good. Walk on your heels like this to the end and come back. Okay. Continue. Then you can turn them back. Good. Now I want you to walk on your toes. On your toes like this. Then to there and back. Good. So during the walking tests, or during the walking tests, we are looking out for any sudden stops and starts. So we're also looking out for what we call the broad-based gait, or Y stance for stability, where the patient is trying to stabilize themselves while they're walking. Okay, so we're also looking for maybe intoxicating walk or drifting to one side during walking. So in cerebellar lesions, the patient will actually drift to the side of the lesion when walking. So we're also looking out for the step regularity, the arm swing, then the truncal stability, and the ability of the patient to turn and walk back at the end of the room. So like we said, in cerebellar problems, when there is a problem with balance, the patient will try to balance themselves while they're walking, thereby developing what we call broad-based gait or Y stance for stability. So these are some of the things we'll observe during the gait of the patient. So for our patients, the gait is normal with appropriate base. The arm swing and the turning were normal, and tandem walk was steady. So after that, we perform what we call the Romberg test, where we tell them to stand with their feet together and the arms to their sides, and we're going to observe them for 20 or 30 seconds to note any sway or instability. Okay, so we're going to perform the Romberg test. Now, this test comes in two phases. First, we perform it with the patient's eyes open, then perform it with the patient's eyes closed. So they will stand with their arms to their sides, and we observe them for 20 to 30 seconds. And during the Romberg test, try to hold your patient, okay, so that in case of any falling or any swaying, you'll be able to hold them. Okay, so can you stand? Put your feet together. No, turn this way. Put your feet together. Okay, so just. Okay, so when you observe for at least 10 or 20 seconds, so can you close your eyes? Don't worry, I'll catch you if you fall. So you observe for also 10 or 20 seconds. Okay, so we are watching for any increased swaying or falling. Now, this Romberg test, so you cannot sit. Now, like we said earlier, we use this Romberg test to differentiate if ataxia or is cerebellar or sensory. In cerebellar ataxia, the patient will be unsteady even with the eyes open or closed. Whereas in sensory ataxia, the patient will be stable with the eyes open, but it will be unsteady with the eyes closed. And this is what we call the positive Romberg, where the patient is stable with the eyes open, but unsteady with the eyes closed. This is due to sensory ataxia. Whereas in cerebellar ataxia, even before the eyes will be closed, the patient will also be unsteady. Our Romberg test was negative, as our patient was stable with the eyes open and closed. So with this, we've concluded our examination on our patient, and the cerebellar examination reveals normal findings for each of these tests. So now we've come to the end of the cerebellar examination. We thank your patient, then present your findings to the examiner. So thank you for allowing me to examine you.
You're welcome.
Okay, so you present your findings to the examiner.